In this session, we're going to focus on some of the key data sources that payers have for data to use for their analytics. We'll look at both typical sources and a few atypical sources. One key source of data for payers is their membership file. This is simply a database of people who are covered by a payer. When you go to a doctor or a hospital, they will query this database to see if you are covered and what benefits you're covered for. When a claim comes in, the patient is looked up in this file, once again, to see if they're covered, what the benefits are, and very importantly, what time period they're covered for. Data included in the membership file includes the group that you get the coverage through, such as your employer, the relationship of a member to the contract holder. Contract holder would be the employee. Relationship could be the employee themselves, spouse, dependent. It contains demographics about the member, their age, sex, geography where they live. As I said, very importantly, the start and end dates. Those are critical for your analytics and what benefits are covered. Membership file is critical for your analytics if you're going to do anything, for example, rates per thousand. You need that denominator, and that's where this comes from, and that's why the coverage start and end dates are so important. So you get your member accounts or member months, another base for analytics. A second major source of data for payers is their claims file. A claim is an itemized statement of services and charges from a healthcare provider or facility that is submitted to a patient or, given our economy, more likely to their insurance carrier. It's a bill. Data on this bill or on the claim includes identification of both the patient and the member, if they're two different people, identification of the provider. It could be a physician's identifier, it could be a hospital identifier, a clinic identifier, the conditions being treated, the patient's diagnoses, the medical services provided to the patient during that claim period, and conditions and the services provided both involve a lot of detailed coding, and we'll be spending another session exclusively on those coding systems. And the date the service was provided. It could be the admission and a discharge date for a hospital stay, it could be the date of an office visit, it could be a span of time. If you're going to chemotherapy twice a week for a month, it might be the beginning and the end of the month with a separate claim for the next month's chemotherapy services. I'm sure all or most of you have heard of HIPAA, the Health Insurance Portability and Accountability Act. If you've gone to a doctor or to a hospital since HIPAA was implemented, you've likely signed a form that says that they've given you their confidentiality and privacy rules. HIPAA requires that your interactions with that provider be kept private. It requires that the data they hold about you be kept confidential and protected, that you have the right to see and protect and change any incorrect information that they have about you. And whenever the data is kept electronically, that it must be protected using certain minimum standards of protection. That's what most people think about with HIPAA. However, HIPAA does also require certain transactions, electronic transactions among players in the healthcare industry. For example, if a hospital issues a claim, they will use a HIPAA standard 837 format. Regardless of what payer they're billing, it'll be the same format. They just need one system to issue a claim. Similarly, the payer, if they get a bill from a hospital, can expect it to be in the 837 format. Makes it easier for them to have a uniform adjudication system regardless of the hospital submitting the claim. When the payer sends back information about the payment they're making, they send it back with an 835 or a remittance advice, explaining to the payer, to the provider rather, what's being paid and why. During this course, we will be spending a lot of time talking about different standards. When we use that term, we mean the HIPAA standards. For example, when we talk about coding systems, we'll be sticking to HIPAA standard coding systems. Since the 837 is the source for a lot of information for analytics by payers, that's the claims files, I provided in the additional readings some reference material with showing you what those specifications look like. There's the 837 inpatient, sometimes called the UB04, Uniform Billing Form 2004, CMS 1450. Those are different buzzwords for the same thing. And I've got I have a copy, a PDF with the form itself, and a Massachusetts version of the instructions. The 837 Professional, the form is also called the CMS 1500 or 1500 claim. I've included an instruction manual on the 1500 so you can see what that looks like. For pharmacy claims, there's the NCPDP claim form, and there's a PDF in the additional readings describing that also. In addition to membership and claims files, some payers, especially if they're an employer health plan, will have additional information that can be used for analytics. One source of atypical data that's available to some health plans, mostly to employers, is absence or lost time data. This is days or hours, or I've seen systems that are in 15-minute increments that show when an employee is not at work. It could be vacation, it could be sick time, personal time, tardiness, any number of reasons, and the systems will vary on how detailed they get for the reasons. But it provides valuable information on when a person is not available to the employer for work. The reason it's so important is if you're out sick, not only are there healthcare costs incurred, but there's lost time. You don't have that employee working. For some jobs, you may have to hire temporary help to come in to backfill that time. And that's a large area of expense that is often overlooked when employers look at their healthcare costs. If you're looking, for example, at the benefits of a wellness program, and the cost of the wellness program is not being offset maybe completely by healthcare cost savings, it may be being offset when you add in the absence time. So from an analytical point of view, absence is a very important, can be a very important adjunct to when you're doing a cost analysis. And it's important to bear in mind that an absence due to an individual's cost, healthcare rather, is not where it stops. You could have a parent with a child with cancer. That parent is going to be out of work a lot, even though it's not their health, it's a dependent's health that's involved. So you have to be creative sometimes when you use the absence lost time data to really paint a good picture of what's going on with your population. Another atypical source of data for payers is productivity data. Productivity is the amount of work product delivered by an employee, usually per unit of time or some other unit of service. A relatively new term in this area is presenteeism. An employee is present, they're physically at work, but they're not fully functional. They could be drowsy from medications they're taking. They could have to make frequent trips to the bathroom. For whatever reason, the medical condition allows them to be at work but not fully functional. This type of data is usually only available to employers, but it can also be very valuable. We did a study once looking at when certain non-sedating antihistamines went over the counter. They used to be prescription only, went over the counter. The prescription medication would have been covered by the health insurance of the employer, but once it became over the counter, even though it was still expensive, it was not covered. And employees were going to take sedating antihistamines simply because it was still prescribed, and there'd only be a $5 copay instead of maybe $20, $30 for the over-the-counter. We did a study for some employers who wanted to know, even though the non-sedating antihistamine was over-the-counter, should they cover it as if it were a prescription still, so that it'd still only be a $5 copay even though it was over-the-counter. And the key issue there was presenteeism. Would they lose more by having an employee who was drowsy from a sedating antihistamine? Would that offset the cost of covering an over-the-counter medication? So a lot of information can also be drawn from productivity as well as absence. Should be noted, though, that only limited types of jobs are really amenable to good, credible, consistent productivity measures. For example, telephone call centers, delivery drivers, types of work where you can measure a consistent pattern, and you could tell if the person is as functional today as they were yesterday or last week. Another atypical source of data for payers is segmentation data. For those of you familiar with marketing, you'll have run into this, where it's customer segmentation It's dividing a customer base into groups of individuals that is similar in certain specific ways that are relevant to your marketing. It could be age, sex, their interests of the individuals, their historic spending habits, anything that helps you categorize how you would tailor a message to that group. In healthcare, it's related to getting messages about wellness or other health-related information to maximize the likelihood that the message will be effective. For example, if you want to get through to smokers about a new smoking cessation program that you would like them to participate in, that message, that information may have to be delivered differently for millennials versus baby boomers. Certain groups may want a brochure in the mail that they can sit down and read. Others don't want anything longer than a simple text or a tweet.